Hi, my name is Adam Cohen. I'm a hematologist-oncologist at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia. And today I'm going to be talking about our abstract looking at predictors of expansion and response in relapsed refractory multiple myeloma patients treated with BCMA-directed CAR T cells. So as we reported at previous ASH meetings, we've been conducting a study of CAR T cells that target BCMA, a molecule on the surface of myeloma cells, in patients who are relapsed refractory with myeloma. 3 different cohorts of patients were examined in this study. The first got just CAR T cells alone at a dose of 1 to 5 times 10 to the 8th CAR cells. The second cohort got cyclophosphamide as lymphodepleting conditioning prior to giving the CAR T cells at a 10-fold lower dose, 10 to the 7 cells. And cohort 3 gave cyclophosphamide with the CAR T cells at a dose of 1 to 5 times 10 to the 8th. As we reported at last year's ASH meeting, in 25 patients who were treated, we saw an overall response rate of 48%, including 7 out of 11 or 63% in the cohort 3 patients who received both the lymphodepletion as well as the optimal dose of CAR T cells. And the toxicities were cytokine release syndrome and neurotoxicity, which were similar to what has been described with CD19-directed CAR T cells and other B-cell malignancies. And so what we were trying to focus on in this year's presentation were understanding why some patients had good expansion of their CAR cells and responded and other patients did not. And so we did an analysis of various clinical features, including patient age, years from diagnosis, cytogenetics, prior myeloma lines of therapy, as well as expression levels of BCMA on the myeloma cell surface or tumor burden. And interestingly, none of those were predictive of who was going to respond or not. What was predictive, however, were certain features within the myeloma, within the patient T cells prior to starting the manufacturing process. In particular, patients who had a higher ratio of CD4 to CD8 T cells in their initial apheresis product before manufacturing, as well as patients who had CD8 T cells with a particular phenotype, CD45RO negative, CD27 positive, which is predominantly a phenotype seen in naive T cells or stem cell memory-like T cells. Patients who had higher CD4-CD8 ratio or that particular phenotype were more likely to have good CAR T cell expansion and good response. So what we think this means is that the actual fitness of the T cells before you start the manufacturing may actually be predictive of how well the CAR T cells are going to work, and maybe something that we can target to try to see if we can make better CAR T cell products going forward. It also suggests that treating patients earlier in their disease course, when they haven't been so heavily pretreated and when their T cells haven't been quite as beat up from all the years of chemotherapy, that we might be able to make better CAR T cell products and have better activity in those patients. And in fact, that's a current trial that we're pursuing at the University of Pennsylvania now, where we'll be taking patients with very high-risk myeloma after they finish their induction therapy. And instead of going to a stem cell transplant, we'll be collecting stem cells, but then treating them with the BCMA-directed CAR T cells or BCMA and CD19-directed CAR T cells. Again, hoping that by collecting those T cells earlier, we'll get a better CAR product and better outcomes.